Thank you for tuning in. As an American Medicine YouTube channel, we bring in the most important medical topics that will help the medical practitioners across the globe. We bring in live seminars every Sunday at 6:30 a.m. Central Time, United States, 6 p.m. IST, and other corresponding time zones across the globe. This particular seminar, we are going to focus on shock, general concepts. We address the issues from neonate, pediatrics, and all the way to adults. In subsequent seminars, we are going to focus on different topics related to shock. Please tune in every Sunday at that corresponding times. And all the seminars will be uploaded in YouTube channel. If you like it, please use it and share it with others. We like to create a big global healthcare community that shares the information to each other. That is our aim of this particular project. Shock is a syndrome that results from inadequate oxygen delivery to meet metabolic demands. In other words, oxygen delivery is less than oxygen consumption. Untreated shock leads to metabolic acidosis, organ dysfunction, and eventually death. Oxygen delivery is equal to cardiac output and arterial oxygen content. Cardiac output is equal to heart rate and stroke volume. Stroke volume is determined by preload, afterload, and contractility of the heart. Arterial oxygen is equal to oxygen content of hemoglobin and the oxygen dissolved in plasma. As you can see, CaO2 is equal to hemoglobin times saturation times 1.34 plus dissolved oxygen in the plasma, which is 0.003 times arterial oxygen content. Another important concept one has to understand is what is oxygen consumption? Oxygen consumption is oxygen delivery times oxygen extraction ratio. So all these variables can be understood and also can be controlled by therapeutic maneuvers. In normal, healthy humans, oxygen deliveries often exceeds oxygen consumption. So the oxygen consumption is not depend on oxygen delivery. But in disease states, the oxygen consumption will become oxygen delivery dependent. That particular point is called critical point. It could be because of many reasons. Most of the time, oxygen delivery becomes less than the oxygen consumption. So there are states where there is a low oxygen extraction happens, especially when you sedate and do a paralysis for the patient. It reduces the oxygen extraction ratio. There are other situations where there is high oxygen extraction and low oxygen delivery situation. For example, if the oxygen given is lower, that can cause low oxygen delivery and high oxygen extraction. And also when there is a severe anemia or when there is a cardiac dysfunction in the form of contractility, rate and rhythm disturbances, afterload and preload conditions can all will affect oxygen delivery and leads to high oxygen extraction. And other shock and hypoperfusion states due to other causes also will result in low oxygen delivery and high oxygen extraction. There are other situations where oxygen extraction is high and also high oxygen consumption, like patient with fever, inflammation, hypermetabolism, exercise, shivering, increased workup breathing, all will increase oxygen consumption and high oxygen extraction ratio. This particular slide summarizes what we have talked so far. Oxygen delivery is controlled by arterial oxygen contents and cardiac output. Let's focus on this limb. Arterial oxygen contents again controlled by hemoglobin and oxygenation. Oxygenation is again by AA gradient, diphosphoglycerate, acid-base balance, blockers, competitors, and temperature all influence oxygenation. Another limb, cardiac output, is heart rate times stroke volumes. The heart rate can affect by drugs and the conduction system disorders. The stroke volume, preload, afterload, and contractility, and ultimately it's all affected or influenced by metabolic milieu, ions, acid base, temperature, drugs, toxins. And blockers could be calcium blockers and beta blockers, competitors, and autonomic tone. There are three stages of shock. Number one, initially, it's called compensated. Once a compensatory mechanism is exhausted, it will become uncompensated, and finally, irreversible, leads to multiple organ dysfunction. In compensated shock, the vital organ functions or maintain, BP remains normal. In uncompensated shock, the microvascular perfusion becomes marginal, organ and cellular function goes down, and hypotension develops. Irreversible, you will have multiple organ dysfunction at that point. So the clinical early diagnosis requires high index of suspicion. Our aim is to identify in compensated shock state so that the treatment will revert completely and prevent further injury to the organs. Diagnosis made through physical exam focused on tissue perfusion. Abject hypertension is a late and premorbid sign, so do not wait till the hypotension develops. The idea is to identify before hypotension develops. This particular slide shows in hemorrhagic shock, it takes 25, even till 25% of the volume loss does not affect the blood pressure. Blood pressure is maintained, of course, at the expense of increased vascular resistance and decreased cardiac output. But if you rely on just blood pressure alone, it will give a false hope. So when in physical exam, just focus on perfusion, CNS perfusion, skin and extremities perfusion, cardiopulmonary and renal perfusions. When there is a decreased perfusion to the brain, it causes fluctuating mental status, sunken fontanelles in newborn. It also will cause cool, pallor, mottling skin, cyanosis, poor capillary refill, weak pulses, and poor muscle tone. These patients tend to have tachycardia and tachypnea, along with scant and concentrated urine. While you are evaluating, just make sure the patient doesn't have underlying heart disease, had a previous any surgeries, steroid use, other medical problems, brief history of present illness, how did this symptomatology evolve, and any exposures, and when did it start, and how did it evolve. So what are the signs of decreased perfusion? Again, there are three grades I wanted to show you. When there is a mild stage, you will see scant urine volume and increased specific gravity of urine, delayed capillary refill, and most importantly, you will see increased heart rate. When it becomes moderate, child will become or patient will become restless, apathetic or anxious, lethargic, increased ventilation, compensated metabolic acidemia, decreased motility, lethargic, and oliguria, cool extremities, increased heart rate, and decreased peripheral pulses. At this point of severe decreased perfusion, the signs and symptoms will become very severe, will become very obvious to everyone at this point. The patient will become agitated, confused, stuporous, sometimes comatose. These patients tend to have severe tachypnea, uncompensated metabolic acidemia, ileus, oliguria, anuria, mottled, cyanotic, cold extremities. They tend to have increased heart rate and decreased blood pressure. So we enter into the uncompensated blood pressure, uncompensated shock at this point. So what are the types of shock? There are 5 of them. They are namely hypovolemic. In hypovolemic shock, there is a decreased preload secondary to either internal or external losses. Internal loss could be hemorrhage or even sometimes into the a fluid loss within the gut or within the abdomen. Plasma loss like burns, nephrotic syndrome, and vomiting and diarrhea causes fluid loss. In cardiogenic shock, there is a pump failure that leads to poor perfusion. You will see cardiogenic shock in patients with congenital heart disease, cardiomyopathies, such as dilated and restricted cardiomyopathy, ischemia or frank myocardial infarction, and arrhythmias, both brady and tachyarrhythmias. In distributive shock, there is abnormality in vasomotor tone and loss of venous and arterial capacitance. You see distributive shock in anaphylaxis and neurologic disorders like spinal cord and brainstem injury, and sometimes it's caused by drugs. Septic shock present will have hypovolemic, distributive, and cardiogenic component to it. In hypovolemia, because of third spacing of fluids into extracellular and interstitial space. In distributive, early shock with decreased afterload. And cardiogenic, because it causes myocardial function being depressed because of endotoxins. Septic shock, as you know, is caused by either bacterial, viral, sometimes fungal. And finally, obstructive shock. It is decreased cardiac output because of the direct impediment for the outflow or restriction of all cardiac chambers. That is being seen in patients with tension pneumothorax, pericardial tamponade, pulmonary embolism, antemediastinal masses, and critical coarctation of aorta. Let's look at the pathophysiology of shock. There are 5 elements to the pathophysiology, how the shock happens in different entities. Number 1, as we talked about earlier, extracorporeal fluid loss. Hypovolemic shock may be the result of direct blood loss through the hemorrhage or abnormal loss of body fluids like diarrhea, vomiting, burns, diabetes insipidus, mellitus, and nephrosis. Hypovolemic shock is the most common shock across the globe. Number 2 is lower plasma oncotic forces. It's again loss of oncotic pressure causes hypovolemic shock that is seen in patients with liver injury and progressive complication of increased capillary permeability as seen in patients with septic shock. Third, abnormal vasodilation, often seen in patients with distributive shock like neurogenic anaphylaxis and septic shock. When there is loss of vascular tone, both venous, arterial, or both, either because of sympathetic blockade, local substances affecting permeability, acidosis, drug effects, and spinal cord transaction. And increased vascular permeability, sepsis may change the capillary permeability in the absence of any change in capillary hydrostatic pressure that happens because endotoxins released from sepsis, or in anaphylactic shock because of excessive histamine release. And cardiac dysfunction. Cardiac dysfunction can cause hypoperfusion. It is because of pump failure by the heart. It could result from ischemia, drugs, constrictive pericarditis, pancreatitis, and sepsis. We are going to look at different hemodynamic variables in different kinds of shock. The first one being hypovolemia, cardiac output is decreased, vascular resistance is high, mean arterial pressures initially in a compensated shock, it remains normal. In uncompensated shock, blood pressure will become lower. Capillary wedge and central venous pressure both will be lower. In cardiogenic shock, output is decreased, vascular resistance is higher, MAP initially is maintained, and uncompensated, it falls. Capillary wedge pressure and central venous pressure both will be elevated when compared to hypovolemic shock. Obstructive shock, cardiac output is decreased, vascular resistance increased, and wedge pressure and CVP, similar like cardiogenic shock, elevated. Distributive shock, cardiac output is increased in contrast to other three we discussed. Vascular resistance will be very low, again contrast to the previous three, and capillary wedge, central venous, and the MAP can be anywhere between normal to low. Septic shock has two components, early component and late component. Early component, cardiac output would be higher, vascular resistance would be lower, similar to anaphylactic shock. Mean arterial pressure varies, capillary wedge pressure and CVP will be lower. Late stages in cardiac output will be decreased. Vascular resistance again will be lower, and the MAP will be low, wedge pressure and CVP will be higher in the late stages of septic shock, because that is because of cardiac dysfunction at that point. Previously, the early stages of septic shock called warm shock and the late stage called cold shock because of the way the patient presents. In warm shock, that is early septic shock, you will have a flash capillary refill, warm and flushed extremities, and bounding pulses. If you do not have a high index of suspicion, you can easily miss shock. Invariably, these patients have tachycardia and low diastolic blood pressure. And then subsequently, if it is untreated, goes into prolonged capillary refill, cold extremities and weak distal pulses called cold shock. But if you resuscitate with the fluids, antibiotics, and removal of toxins, in some cases, you can revert back to warm shock and eventually normal. The next section, we are going to talk about the criteria for organ dysfunction that results from shock states. When do you call the patient has cardiovascular dysfunction? Despite the fluid administration, more than 60 ml per kg per hour in 1 hour, continue to have hypotension in spite of fluid challenge, or need of vasoactive drug to keep the target MAP, mean arterial pressure, or two of the following: metabolic acidosis, increased arterial lactate, oliguria, prolonged cap refill, that means more than 5 seconds, and core to peripheral temperature gap of more than 3 or 5.4 degree Fahrenheit. When do you call respiratory dysfunction? When the PF ratio is less than 300 in the absence of cyanotic heart disease or pre-existing lung disease. PaCO2 is more than 65, or need for FiO2 of 50% or above to maintain the saturation of 92, or need for non-selective invasive or non-invasive mechanical ventilation. When do you call neurologic dysfunction? GCS scores less than 11, or acute change in the mental status with the decrease in GCS scores more than 3 points from abnormal baseline, or platelet counts less than 100, or decline of 50% of platelet count from the highest value recorded over the last 3 days, INR more than 1.5, or activated prothrombin time more than 60 seconds, that constitutes hematologic dysfunction. The renal dysfunction is defined when the serum creatinine is more than 0.5 or more than 2 times of upper limit of normal age, or twofold increase in the baseline creatinine value. The hepatic dysfunction is defined when the total bilirubin is more than 4 milligram per deciliter, and ALT 2 times the upper limit of normal for age. Differential diagnosis of shock. The precise etiologic classifications can get delayed. When the patient comes to the shock, it is an immediate medical intervention is necessary. Absolute relative hypovolemia is common in all shock states, including cardiogenic shock. The size of the cardiac sellout in plain film may indicate whether the patient needs more volume, or if the heart is generous, you need to give fluid boluses very gingerly, 5 to 10 ml per kilo. Another unique group is shock in neonates. When you have a shock in neonates, make sure you are not dealing with congenital adrenal hyperplasia, inborn errors of metabolism, obstructive left-sided cardiac lesions, aortic stenosis, hypoplastic left heart syndrome, coarctation of aorta, and interrupted aortic arch. So how do you manage patient with shock? Either increase oxygen delivery or decrease the oxygen demand. How do you do that? By providing oxygen, providing fluid, temperature control, early antibiotics, correct metabolic abnormalities, and providing vasopressors. As in any critical illness, make sure airway is patent. If it's unable to maintain it, intubate the patient. Number 2, breathing. Always give 100% oxygen in patients with shock, at least to start with. Monitor saturation and establish IV access rapidly. If an IV access is not established quickly enough, go ahead and do intraosseous line and hook up the patient with cardiorespiratory monitor, and the blood pressure needs to be measured very frequently. Mostly we'll do 3 to 5 minutes. Lab studies depends upon what you suspect. If you suspect infection, draw culture, inflammatory markers, including CRP and procal, CBC count with the differential, and in trauma patients, and draw coag studies, including TAG. And if you suspect endocrine issues, cortisol, calcium level, thyroid, glucose, and ammonia. In cardiology, if suspect cardiogenic, get BNP and troponin I, if you suspect dissociative hypotension, get the carboxyhemoglobin and cyanide level. I want to show this early study that was done in 1991. It's a retrospective study, but it had an influence on the medical community for the next 20 to 30 years. It is a retrospective study done in 34 pediatric patients, collected from 82 to 89. This particular study, hypovolemia was determined by capillary wedge pressure, urine output, and hypotension. Overall, the patients received 33 cc per kilo at 1 hour and 95 cc per kilo at 6 hours. There were three groups. The first group received 20 cc per kilo in the first hour. The second group received 20 to 40 cc per kilo in the first hour, and third group received 40 cc per kilo in the first hour, greater than 40 cc per kilo in the first hour. There were no difference in ARDS between these three groups. But when you look at the total deaths, which is higher in the first group, 14 out of 8 patients died. And group 2 received 20 to 40 ml per kilo in the first hour. 7 out of 11 died. The third group, who received more than 40 ml per kilo, only 1 death out of 9. That prompted give 20 ml per kilo 3 times to reach 60 ml per kilo. That standard persisted almost 30 years since that publication came out. I want to show you how the newborn algorithms for shock being followed. When you suspect shock in newborn, give a fluid bolus 10 ml per kilo, use isotonic crystalloid, and you can repeat the bolus 10 ml per kilo to the max of 40 ml per kilo. Make sure the patient does not have hypoglycemia and hypocalcemia that needs to be remedied right away. The patient the blood pressure didn't perk up with the fluid bolus alone and start dopamine. And if you suspect any kind of cardiogenic, add dobutamine. If the patient is fluid refractory and dopamine resistant, then the practice is to start epinephrine. If the shock persists in spite of all these maneuvers, then you group them into 3. 1, low blood pressure, warm shock, meaning the capillary refill is good. In those patients, one should add norepinephrine or vasopressin and monitor the venous oxygen saturation needs to be kept more than 70%. Another group is cold shock with poor left ventricular function. Those patients, and pulmonary hypertension, those patients need to be started on inhaled nitric oxide or inhaled prostaglandins, along with IV milrinone or amrinone. Another group is cold shock but not normal blood pressure. In those patients, add vasodilators such as milrinone or amrinone with volume loading. If the patient did not respond, make sure there is no pneumothorax, pericardial effusion, and if there are no remediable reason for the refractory shock, the patient goes to ECMO. This algorithm talks about shock in infants and children. When you see decreased perfusion with altered mental status, begin high flow oxygen, and establish IO or IV access according to PALS. If there is no hepatomegaly or RALs or crackles suggestive of cardiac dysfunction, go ahead and give 20 ml per kilo of isotonic saline boluses and reassess after each one to the max of 60 ml per kilo, or till the patient develops crackles, hepatomegaly, or other signs of fluid overload. If the patient did not respond, the blood pressure didn't improve, that means the patient has a fluid refractory shock. Begin peripheral IV or IO inotrope infusion. Start with epinephrine, and at that point, the patient may need to get intubated, use atropine and ketamine. If the patient has cold shock, start with epinephrine. If the patient has warm shock, start with norepinephrine. In the absence of epinephrine, norepinephrine, if it is not available, one can use dopamine. The patient blood pressure didn't improve with all those vasopressors, we consider as catecholamine resistant shock. Consider using hydrocortisone. At that point, have monitoring devices like Doppler ultrasound, PICO, FATD, or PAC catheter in place. The idea is to maintain or reach the goal of normal targeted MAP, targeted CVP, venous oxygen saturation more than 70, and cardiac index 3.3 to 6 liters per minute. If the patient still not responding to all those maneuvers, just categorize whether the patient has warm shock, cold shock, or normal blood pressure with cold shock. Low blood pressure with warm shock. If the patient is not already on norepinephrine, go ahead and start that one or add vasopressin. Again, target is to reach the cardiac index of 3.3 liters per minute. One can add epinephrine, dobutamine, enoxaparin, levosimendan as needed in those patients. When the patient is low blood pressure and cold shock, add norepinephrine to improve the blood pressure or increase the cardiac index. Again, consider dobutamine, enoxaparin, levosimendan, and milrinone. And you have to be very careful, especially when the blood pressure is low, when you use the vasodilators. When there is a normal blood pressure and cold shock, begin milrinone infusion and monitor the cardiac index. And the other medications one can consider levosimendan if milrinone is not successful. When the patient is persistent catecholamine resistant shock, make sure that the patient does not have a pneumothorax or pericardial effusion or IAP, that is intra-abdominal pressure, more than 12. If there are issues like pericardial effusion, pneumothorax, and abdominal pressure is higher, that needs to be remedied. If the patient is still refractory, then the patient will end up in ECMO. We want to dissect further how to resuscitate the venous system. Venous system has two components, unstressed volume and stressed volume. Again, the venous return also influenced by whether the patient is spontaneous breathing and positive pressure ventilation. Even among the positive pressure ventilation, whether the pressures are optimal or real high. The venous return to the heart is determined by the pressure gradient between venous filling pressure and the right atrial pressure, so that the flow can happen from the high pressure to the low pressure zone. The venous reservoir represents almost 80% of the blood volume in the circulation. The next slide will talk about unstressed and stressed volume. Let's focus on spontaneous breathing and the positive pressure ventilation. How does it affect the venous system? When you are in a spontaneous breathing, your intrathoracic pressure is negative. The diaphragm contracts, creates a negative intrapleural pressure or intrathoracic pressure. As a result, the venous blood easily goes into the right atrium, which is preload for the heart. When you intubate the patient, you create or change intrathoracic pressure from negative to positive. As a result, the venous return to the heart is impeded. In optimal setting, it doesn't affect that much, but if the pressure is high, as it happens in patients with ARDS, that definitely will have impact on right atrial or cardiac preload. Let's look at how the stressed and unstressed volume in the veins affect. The vast majority of the blood in the venous system is unstressed volume. That is the lower half of the bottom that gives some blood flow to the right atrium, but the stressed volume is the one that improves venous return to the right atrium or preload. How do you improve it? By adding volume to the stressed volume, thus improve blood flow to or blood return to the right atrium. There is another way of doing is using vasopressor, especially the norepinephrine causes venoconstriction, thus aids the flow to the right atrium, thus improve the preload of the heart. The next question is, what kind of fluid do you use? Crystalloid fluid administration is recommended for initial therapy across the board. Balanced crystalloid should be considered, especially in the absence of hyponatremia or in patients with severe traumatic brain injury. Albumin administration may offer benefit in patients with sepsis. Synthetic colloids such as hydroxyethyl starch and gelatin should not be used. The current strategy is restrict fluid administration. It might reduce the morbidity and mortality, but confirmatory data is needed. As of now, conservative fluid management is necessary. The traditional time course of therapy, as soon as you suspect, this is from septic shock, start antibiotics immediately without any delay. Second, give aggressive fluid resuscitations to improve the stress volume, thus improve the preload. If the fluid challenge fails to improve target MAP, add norepinephrine, vasopressin, epinephrine, and testosteroids. But the current understanding questions the previous one. This current practice is start the antibiotics without any delay. Use the fluids conservatively so that they will not end up in ARDS, pulmonary edema, and other fluid overload situations. Start norepinephrine along with fluid boluses rather than waiting for the fluid therapy to fail, then start norepinephrine. In subsequent slides, we will give you when to start, what are the parameters you need to monitor. If norepinephrine doesn't improve target MAP or diastolic blood pressure, add epinephrine, vasopressin, and subsequently hydrocortisone, vitamin C, and thiamine. There is no difference in outcome whether the central venous catheter is used or not. The early goal-directed therapy published in 2001 shows you need to have a CVP and you need to maintain or monitor the venous oxygen saturation that needs central venous catheter. Presence of CVC is not a prerequisite for starting vasopressors. Vasopressors can be started safely using peripheral vein while waiting to place central venous line within less than 4 hours, of course. When you do a peripheral venous catheter to give vasopressor, it's preferable to do in forearm and upper arm and use venous catheters 20G or larger. And the IV site should be assessed every 1 to 2 hours for signs and symptoms of extravasation. Norepinephrine is recommended by Surviving Sepsis Campaign as the vasopressor of choice. Norepinephrine increases blood pressure. It boosts ionotropy. The sepsis-induced systolic dysfunction present in 50% of the patients. It causes venoconstriction, thus improve right ventricular preload. Causes arterial vasoconstriction, thus improve mean arterial pressure. Yearly administration of norepinephrine is associated with increased shock control and lower incidence of cardiogenic pulmonary edema. In presence of hypotension, start norepinephrine along with fluid bolus, especially when the diastolic blood pressure is less than 50. When the diastolic blood pressure is more than 50, begin norepinephrine to keep the MAP 65 or above. Of course, norepinephrine has side effects, cardiac arrhythmias being the most common. The cardiac arrhythmias are seen in 2 to 15% of patients when you use norepinephrine, and seen in 15% of patients when you use epinephrine, and 25% of the patients when you use dopamine. It also can cause symmetrical peripheral gangrene, otherwise called SPG. When it develops, it's associated with high mortality. The good news is oftentimes the SPG develops because of DAC rather than the vasopressors. Norepinephrine can cause myocardial ischemia, mesenteric ischemia, and digital ischemia. That adverse reactions happen in 10% of patients. If the target MAP is still cannot achieved with norepinephrine dose 30 to 50 mics per minute, it's an adult dosing, add vasopressin 0.01 to 0.03 units per minute, or epinephrine to reach target MAP. Vasopressin does not act through the adrenoreceptors. It acts through V1A receptors and vascular smooth muscle that are found in both arteries and veins. The vasopressin may be dosed up to 0.03 to 0.04 unit per minute. The higher doses of vasopressin are not recommended because of the concerns of splanchnic cardiac and digital ischemia. Epinephrine is alpha and beta adrenergic agent that increases MAP, mean arterial pressure, and cardiac index. It may increase lactate levels through the beta adrenergic driven increase in aerobic glycolytic lactate production. Dopamine also can increase mean arterial pressure and cardiac output, but the recent meta-analysis says the routine use of dopamine as first-line vasopressor agent in the management of septic shock was associated with greater mortality. Other issues, the SS Surviving Sepsis Campaign suggests placing an arterial catheter as soon as practical. Starting dose and rapidity of titration are depend on severity of hypertension and the response. Following volume expansion, the maintenance of MAP target requires higher ranges of vasopressor therapy. The one should give IV hydrocortisone. The dose is 200 mg per day, which is 50 mg IV 6 hours, or initial dose of 50 mg IV followed by 200 mg as a continuous infusion. Question is when to give hydrocortisone. When the MAP or when the target MAP is not reached with a norepinephrine of more than 15 mics per minute or more than 0.1 mic per kg per minute of norepinephrine, one should give hydrocortisone. Dobutamine, another ionotropic agent, It's considered in patients with suspected or measured low ejection fraction. It increases cardiac output, improve the blood flow and oxygen delivery to the tissues. Dobutamine may lead to cardiac arrhythmias and myocardial ischemia. It can cause hypotension. I want to have a word with the importance of diastolic blood pressure. Decreased diastolic blood pressure correlates with severity of arteriolar vasodilation. DBP is a very important marker of arterial tone. And most importantly, it perfuses the left ventricle during diastole. So diastolic blood pressure is a very important implication in the perfusion of myocardium. So low diastolic blood pressure impairs myocardial perfusion, especially during tachycardia where the diastolic time is limited. Titrate the vasopressure to keep the diastolic blood pressure more than 50 millimeter of mercury as long as MAP is no higher than 85. Diastolic blood pressure is more accurate with an arterial line. So early placement of arterial catheter is very necessary. Norepinephrine increases diastolic blood pressure by restoring vascular tone. This slide shows the normal diastolic blood pressure in different age group. The 50 is for an adult. In children, we do not have particular diastolic blood pressure, but you can use this particular lower number to aid in your therapeutic decisions. They maintain mean arterial pressure and the right mix of fluids and vasopressors. In 2001, early goal-directed therapy came with an emphasis on early identification of sepsis, starting earlier antibiotics, and early aggressive fluid resuscitation. From 2010 onwards, there are growing concerns about the potential consequences of overly aggressive fluid resuscitation in septic shock. As a result, when you treat and make sure the patient is not fluid overloaded by monitoring and also looking at the clinical signs like cerebral edema, pulmonary edema, hepatic congestion, pericardial effusion, acute kidney injury, ascites, intestinal dysfunction, dilutional coagulopathy, hypervolemia and hypertension, and peripheral edema. I personally look at the fluid balance every day and body weight change, extravascular lung water by thermodilution, cardiac ultrasound, look at lung for the fluid, blood pressure and central venous pressure, kidney function, intra-abdominal pressure, electrolytes, bioimpedance if it is available, and biomarkers such as acute kidney injury or gall, glycocalyx degradation markers, so on and so forth. Finally, we are going to walk through how to manage hypotension. The patient presents with hypotension, meaning MAP less than 65 or serum lactate level more than 4. If the diastolic blood pressure is more than 50, infuse 30 ml per kilo of balanced crystalloids. If the diastolic blood pressure is less than 50, start the infusion of balanced crystalloid 30 ml per kilo and start norepinephrine infusion. Titrate to keep the MAP 65 to 70 and diastolic blood pressure more than 50. When the MAP target of 65 achieved and the lactate level is downtrend, and monitor them. If the MAP was not achieved and lactate is not showing any downtrend, initiate epinephrine infusion and also assess the fluid responsiveness of the patient with dynamic test. And other group, if the patient is reached the target map, this group is receiving both norepinephrine infusion and the fluid bolus achieved, and serum lactate downtrend. If he's doing okay, look at the diastolic blood pressure. If it is more than 50, monitor. If the diastolic blood pressure is less than 50 and go up on the norepinephrine infusion in that patient, and assess the fluid responsiveness with dynamic tests. If the dynamic tests are good, look at the norepinephrine requirement. If it's less than 10, do not consider more fluid bolus. If the norepinephrine requirement is more and balanced fluid boluses, and of course you monitor with the dynamic tests. And you need to monitor the oxygenation frequently too. If the patient is not responding to the fluid bolus and dynamic tests are not showing the patient is fluid responsive, and you need to titrate the norepinephrine infusion. If the patient is not responding at that point, add vasopressin and add hydrocortisone. If the patient is responding well, and monitor the patient. After adding vasopressin and hydrocortisone, if the patient responds well, and monitor them, and the resuscitation is good. In spite of all this, epinephrine, vasopressin, and hydrocortisone, if the patient is not responding, and make sure the source control is good. And echo the patient, make sure there is no underlying cardiac dysfunction. If there is a cardiac dysfunction, meaning ejection fraction is lower, then consider using or use dobutamine or milrinone in those patients. This concludes the talk on the shock general concepts. We are going to talk about septic shock next weekend, Sunday. If you like it, please like it and share it with your other colleagues. Since it talks about neonates to all the way to adults, please share it with all medical professionals. Please leave your comments about the presentation and the content. And if you like more information on any medical topic, please let us know. Thank you for listening.